BMI is 30. What do we call that? BMI 30. Obese. Okay, but he's just barely, obese. So, okay, and he comes in and he says, I've been driving this truck and I noticed that I have pain and it's kind of up in my upper stomach and sometimes it's in my chest. It's been going on for about a year. When I wake up, it's when I mostly notice it, and then when I eat breakfast, it gets better. Sometimes it comes back in the afternoon, and then a lot of times it's worse late in the day. And he doesn't have any nausea. He doesn't have any vomiting. He's perfectly healthy. He had his tonsils out when he was 12. He's never had any surgery. He smoked a pack a day since he was 18 years old. And on the weekends, he drinks a 6-pack of beer. He doesn't use illicit drugs. But sometimes when he has a headache, he takes goody powders. And you ask him, well, how stressed out do you feel by your lifestyle? And he says, well, not some, not real stressed out. So you do a physical exam on him because that's what you're going to do on everybody, and it's absolutely normal. You do a CBC on him. His hemoglobin's 15, white count's 9, platelets are 150. All his electrolytes and all of his liver tests are normal. Okay, what do you want to do with this guy now? Everything's normal. He's complaining of this kind of vague. Does this remind you of any specific syndrome? They don't remind me of one. I mean, it's got components of a lot of things. So, what lives there? So the first question I always ask when the patient says, it hurts like right around in here. Well, what lives there? Your stomach lives there. Some of your hepatic ducts, like your gallbladder, empties. Your gallbladder's over here, but it empties there, in the middle. Aorta's there, but what's kind of around the middle. Esophagus, heart is in the neighborhood, so those are the things I would think of. So what do you want to do? You want to send him for a cardiac cath? Probably not.
24-hour
Okay. What?
24-hour PH.
Okay, that would not be a bad thing. Your differential would be something like gallbladder disease, GERD, stomach ulcers, something else, something weird. What do you do next? Certainly 24-hour pH monitoring would be not a bad answer. I just chose to send for a scope. But the 24-hour pH is not wrong. Okay, I might have sent him to get his gallbladder. Ultrasound and gallbladder, pretty cheap, fast, non-invasive. I might have ultrasound his gallbladder and sent him for a scope. Okay, and 24-hour pH monitoring is not wrong. Okay, so this is what you see. You're looking down there. This is the distal esophagus here, and right at the GE junction, and this is what you see. So which of these do you not want to do? You want to biopsy his mucosa? Okay, all right. Do you want to treat him for H. pylori? Well, what do we call it? If our biopsy came back columnar metaplasia and tested metaplasia, it depends. It's kind of a trick question, okay? So if you just see some esophagitis and you don't think it's Barrett's, then you probably don't really need to treat for H. pylori. But most patients that you're going to have on prolonged PPIs and stuff often get atrophic gastritis, and you might want to, but certainly not my first answer, okay? You want to tell them to stop smoking? Okay, you're probably going to put them on something to reduce acid medication, and when would you do an esophagectomy? If your biopsy came back cancer, okay, all right. So if this biopsy came back cancer, you would do esophagectomy, okay? So this is not necessarily all one right answer. I'm putting these things on here so we can discuss what it is. So you send this guy, you do the biopsy, it comes back columnar mucosa, so it is Barrett's esophagus, but there's no dysplasia, okay? So the guy's not in danger of getting esophagus cancer 2 years from now. And you instruct him to go home, lose weight, stop smoking, stop drinking, put your head up on the bed, don't eat within 3 hours of going to bed, and take a proton pump inhibitor every night before you go to sleep. Okay, now when would you consider operative therapy? So I think Lauren covered some of this too. If he developed a stricture, would you consider it operation? Absolutely. If he had a surveillance biopsy that showed he had worsening or metaplasia or dysplasia, absolutely. But for metaplasia, for dysplasia, you might go further than that. If the guy kept getting pneumonia, yeah, and this is what you see in the kids, okay, so not in the adult, but the pediatric population, they'll get pneumonia over and over because they have GERD and they'll end up going that. Okay, and you have maximal medical management for any resolution of symptoms? Yes, those are the people you want to send for operative things. Okay, so 6 months later, he comes back to your office and he says, look, I feel a little bit better, but I'm still having this reflux 3 or 4 times a week. So what do you want to do? The 24-hour pH monitoring is the definitive test for GERD, okay? So you may want to do that. You may repeat endoscopy. I probably would if he's still having symptoms at 6 months, because I know he had Barrett's esophagus, right? So I want to see, what that looks like now. What I want to do in esophagram. Well, are you going to consider this guy for surgery now? He's still having reflux. You are. So do you want an esophagram? You should get an esophagram because you want to see what condition his esophagus is. What are we specifically looking for on the esophagram? Do you know? Shortening. Okay, that the esophagus is short or stricture. Those are the 2 things we're looking for that you might see better on esophagram than on repeat endoscopy. Manometry. What are you looking for with manometry? The sphincter tone. Does the lower sphincter work or does it not work? Is it hypertonic? And then, so you may, if you're considering surgery and you have long-standing reflux, you want to do all of these tests, except you might not want to do the 24-hour pH monitoring. But if you didn't know if it was GERD, say you thought it might be something else causing the trouble, you might want to get the 24-hour pH monitoring. So let's say you send him esophageal pH shows numerous periods where the pH is less than 4. I don't want you to learn the Demeester score. It's just one of several scores they do to tell. But the 15 and higher are bad. Maybe the patient needs an operation. 16, and the remainder is normal. Okay, so what are you going to do? All the rest of his tests are normal. What operation should you do? I talked to the patient pre-op. Okay, well, I'll go into some of those. So, no surgery, continued medical therapy would be only if the patient doesn't have dysplasia and doesn't want to have an operation. Otherwise, you would recommend surgery. Okay, say that the surgery he should undergo, that you're probably going to do a Nissen on uncomplicated GERD. Okay, and these other operations are for complicated GERD. All right. Okay, so the patient has good relief with medical therapy. The same guy, we'll just pretend like now he comes back 5 years later and complaining of some difficulty swallowing, and this is what you see. You know what that is? There's a stricture, and it's also shortening because the stomach, some of your stomach is above the diaphragm. Remember, doctor, the ED junction is kind of right above the diaphragm, and now the stomach's been pulled up here because the esophagus is short. All right. So what operation do we do for that? It's in your book. That's where I'm covering it. Okay. So for that one, so I'm going to go over all these. For that one, you do a callus gastroplasty. I'm going to show you what these things are and why they are. So in this implantation, what you do is you put a bougie, which is a long tube about this big around down the esophagus. Because the one thing you don't want to do with any of these procedures is what? Completely block the esophagus off so they can't swallow. So you put a big old wadded up tube down it, and then you take this. You take the stomach, and if you wrap it all the way around 360 degrees, that's called a Nissen. The patient really needs to just have esophageal GERD. That's it. I mean, if they have problems with their sphincters and stuff like that, or they're short, that's not a good operation. If the patient has problems with their sphincter function, or they don't, or the esophagus doesn't have good motility, then you may want to just do this Toupet or Belsey. And Belsey, it's a 270-degree wrap, because if the lower esophageal sphincter doesn't function properly, you don't want it too tight. Okay, you want it a little bit looser. All right. And then this is the callus gastroplasty. For callus gastroplasty, you go in. This is usually done laparoscopically, and the patient's esophagus is up in. The stomach is up in the chest. You pull everything back down into the abdomen, and then you create a fake esophagus for them by taking a stapler and stapling down through. This is supposed to be the bougie in there here. You just kind of create a new esophagus by stapling a row of staples right there, and it gives them a little bit more length, okay, that they can have. It's not a real esophagus, but it'll function like one. All right, and then and this just kind of shows you. And then after the callus gastroplasty, for most patients, you're going to then wrap them, okay? Either 360 or 270, depending on the function. So this is just a slide to kind of help you decide which one is appropriate for each one of these situations. So if the patient has a normal lower esophageal sphincter, it's at a normal length, and it has normal normal motility, you're gonna do a Nissen. Okay, if they don't have good tone in there, but the length is okay, or if the esophagus motility study, the manometry study, shows that it doesn't move very well, because it gets scarred up with all that GERD and it might not move, then you're gonna do a partial fundoplication, either I think they put the Belsey in your book, but probably most people do the toupee procedure. Okay, and then if you have bad tone and the esophagus is short, if it's short, you have to do the cholesgastroplasty for shortening of the esophagus. Now, if the patient has stricture disease, you can do, if you can dilate the stricture, you probably would not want to do a Nissen on somebody you had to dilate the stricture on, because they're probably going to have trouble swallowing afterwards, okay? So if you can't dilate the stricture, so they have a stricture, and they're vomiting everything, what do you, yes, sir? Somebody has, how do they present, or how long? Well, it doesn't take that long. I mean, over a period of a couple months, you're going to see some, metaplasia, and usually within a year, if it doesn't resolve, you'll see the metaplasia, not the metaplasia, but the dysplasia. And when they get this plastic, then they're at risk of esophageal cancer. But the people that continue to have symptoms need to be scoped again. Okay, because the only way to tell what kind of plasia you got is the biopsy. Okay, all right. So now the cholesgastroplasty. Anybody that has a short esophagus, it's called cholesgastroplasty. So that'll kind of explain to you maybe a little bit better. This is in your book, so I want to make sure we at least went over it with you so you have some kind of idea. Okay, so this is the guy. You give him the first time he comes, a 35-year-old truck driver who's obese. You give him a prescription for Nexium. He goes out. You don't see him again. He shows up 10 years later, and he says, "Boy, this symptom's gotten really bad. I'm having more sensation, and yet now he's smoking 2 packs a day. He got laid off from his job. He's drinking a lot now. Has been for the last 3 years." But he said, "But good news, doc, I lost 20 pounds. I lost 20 pounds." So you go, "Well, we're gonna have to see what you got in there." You look in there, that's what he's got. What do you think that is? Cancer. Okay, right. So for cancer, you're gonna do esophagectomy. For strictures that cannot be dilated, you're gonna do esophagectomy too. Okay, so that's when you're gonna give them esophagectomy for these. Okay, which of the following is not an indication for total esophagectomy with GERD? Presence of a stricture. Presence of a stricture, an indication? No. Okay, presence of an undilatable stricture. Okay, so that's the reason I'm like to that. High-grade dysplasia? Yes. Okay. Esophageal cancer? Yes. Okay. So, all right. All right, same guy, 35-year-old guy, drives a truck, has intermittent pain. I mean, exactly the same symptoms, all right? And he comes in, and he's got these tests. Say you did the 24-hour esophageal monitoring, it was negative. All right, then what are you going to do? That was good. Yes, you're going to scope. I might scope and begin with, as I said, but that just depends. So yeah, you're going to send him for a scope. So here's this guy. Here's an ulcer in the first part of this is where you go through the GE junction. It's in the first part of the duodenum here. He's got an ulcer. All right. You should After biopsy and testing for H. pylori, you should tell this patient he should be treated with a PPI for 8 weeks. He most likely will be H. pylori positive. 10% of patients with H. pylori are going to have a recurrence. You should take a course of bismuth, subsalicylate, metronidazole, and tetracycline, or all of these. All of them. Yeah, that's what you're going to do to treat this guy. Good. All right. Okay, if the patient, so let's say he didn't present like that. Say he presented vomiting blood, and you came in to see him the next morning. His hemoglobin was like 12. He was stable. Came to see him next morning. Let's say he saw him, and he called the GI guy, and he scoped it 2 days later. And so he presented with GI bleeding, not pain, which is false. See, this is how these questions are. You got to watch if it says false. Which one of these is false? H. pylori testing with biopsy for urease may not provide accurate diagnosis. Is that true in the patient that's had a GI bleed?
It's true.
Yes, it's true. Okay, so if the patient's had bleeding, the usual test that we use, which is that urease test, is often incorrect. Okay. Long-term PPI treatment may be needed. Is that true?
Yes.
Okay, so the guy that came in with an ulcer, it's not a complicated ulcer. It didn't perforate, it didn't bleed. That guy gets 8 weeks of therapy, and that's it, unless he continues to have symptoms. Okay, because most of those patients are going to resolve, and you treat them for H. pylori, that's it. They're probably going to be well the rest of their life. If the people who come in with the GI bleed, that's complicated ulcer disease, and they need some kind of therapy, usually for life. You can give it a long-term PPI. What's the other thing you can give instead? Sucralfate in your book. Okay, so sucralfate. Okay, so both PPIs and H2 blockers have similar results for healing gastroduodenal ulcers. True or false? False. PPIs have better results. Okay, and that's in your book. Okay, if his biopsy is negative for H. pylori, this guy, so he's had a GI bleed now, and you biopsied him and it was negative, you may ask him to take a urea breath test. Is that true? Yes. Okay. So always do the biopsy because you're in there anyway. May as well biopsy. But if it's not good, do the other. And some people treat. I'll tell you that in practice, a lot of people just treat everybody for H. pylori, no matter where the ulcer is or anything else. They give it to all of them in practice. But okay, all the statements are true. Well, that statement is not true. So that makes that really hard. Okay. All right. Okay. There's no good answer to that question. Which statement is false regarding sucralfate? Okay, so the patient says, "Oh, I don't want to take the PPI. I heard I might get bone density problems if I take a PPI." You're like, "Okay, well, you could take sucralfate instead." Okay, so what's false in this one? This compound coats the stomach and duodenum, binds bile acids, inhibits pepsin secretion while stimulating mucus prostaglandin and bicarb ion secretion. Is that true? Yeah, that's good. I wouldn't have been able to process that fast. Yeah, that's true. Okay, it is an alternative to long-term PPI used for bleeding peptic ulcer. Is that true? Yes, it is an alternative for long-term. Okay, side effects are usually minimal. True? There's typically no side effects to sucralfate. It's really rare if somebody has a side effect. It's just kind of something to coat your stomach. Okay, at a dose of 1 gram 4 times a day, 80% of patients with ulcer will be eradicated in 4 weeks. Is that true? I took that right out of your book. Okay, all right. It should never be used in a pregnant patient. False. That is the treatment of choice for pregnant patients with ulcer disease. Okay, so that's in your book too. All right. Okay, so now here, this same guy now comes in with a bleeding ulcer, not the one where you come in 2 days later, that the guy is dying in the ER, vomiting blood all over the place, blood pressure 70/40. Okay, you're going to give him some fluids, you're going to get some blood hanging, you're going to call GI guy and tell him, "Get your butt in here right now, this guy's going to pass away." All right, so he comes in, and then he calls you. This is what happens to me. I'm like in bed, 3 o'clock in the morning, like, "Come in here, I want you to see this." Okay, so run and look, this is what I see. What is that? That's an artery bleeding out right in front of his face. So there's a bunch of things GI people can do. They can try to staple these. They can inject with different compounds. There's several different ones. They can do epinephrine. There's some other ones out there that to try to stop the bleeding. Again, they can try to burn it, like cauterize it. So there's a bunch of stuff they can do. But this guy's going, "Look, I've been here for an hour trying to stop this with all these techniques, and it will not stop." So now what do you do? Okay, your next step, you're going to put him on put him on a proton pump inhibitor drip? No, you probably already did that anyway, right? Talked where the GI guy got there. Go to the operating room for vagotomy and tracheotomy. Go to the operating room for vagotomy and pyloroplasty. Go to the operating room for a 3-suture ligation or none. Which one? Ligate, right. You go to the operating room for 3-suture ligation. You might do one of these other procedures, maybe, but usually that's a big operation, and somebody that's hypotensive, you probably don't want to do a vagotomy and tracheotomy right now. Okay, it's probably not the right answer. Okay, so most of the time it's the gastroduodenal artery, and where these things usually bleed in the duodenum, it comes to a T right there. So the reason we say you got to ligate 3 spots is because you have to ligate before it. You have to do a proximal, you have to have a distal, and then you got to get around the T. And to do that, you do a U-stitch, pretty similar to that horizontal mattress thing y'all did today. Not exactly, but kind of like that. And you tie it. So you have to tie it in 3 places to make sure it doesn't bleed. And some people will over-sew it as well. It will actually put the 2 edges back together. And most of the time, we're not going to do a big whopping operation like a vagotomy and then tracheotomy because the patient's in bad condition and we're afraid they won't heal. Okay, you might think about doing a highly selective vagotomy, maybe, but most of the time we're just going to ligate them and then try to treat them for their disease. Okay, if they've never been treated before, we're going to treat them for H. pylori, we're gonna put them on a proton pump inhibitor, and maybe go back and take a look, 6 months later and see what it looks like in there, maybe 6 weeks even. Okay, so here's this guy, you did this, you saved his life, woo-hoo for you, okay, he goes out, living his life, and then 3 years later, he comes back, and he's vomiting up everything he eats. Okay, I mean, he's like, I cannot keep anything down. Sometimes I can take some real thin, I can drink some broth, and I do okay, but that is all I can do. And so you work him up, and you send him, and this is your X-ray. What's that? Yeah, he's got gastric outlet obstruction, but it's the same thing. I mean, polycystic, they think more of a baby. That's what we call it then. It's not wrong to call it polycystic, but I think the book would say gastric outlet obstruction. So that's now he's got complicated disease. Okay, so this is all he has going through there, this little tiny string of contrast. So this guy's in trouble. He's not going to be able to eat or get nutrition. All right, what's the next question? What are you going to do? Okay. If you do a highly selective vagotomy, so here's what you do with highly selective vagotomy, the vagus nerve, instead of going up here, this is called the trunk of the vagus nerve at the bottom of the esophagus, and peeling it off and cutting it in two so that he doesn't have any vagus nerve stimulation. Instead of doing that, which causes a lot of complication, changes in the way that your GI tract works, and those are listed in your book, by the way. But if you do that, instead of doing that, you just want to just disrupt it to the stomach. So you come down to what they call the crow's foot here, and it's not nearly this obvious. Believe me, it is not inked in black for you. So, and it's one of the reasons that a lot of people don't like highly selective vagotomy, because sometimes you miss some of them. And there's one particular nerve called the nerve of bladder jet that's pretty easy to miss because it goes on the back side of the stomach, which they didn't even bother to draw that for you, and then the patient may not get relief of symptoms because you missed the nerve of bladder jet kind of thing. But you disrupt all of this through here, and that would be a highly selective vagotomy, and that would be a treatment for peptic ulcer disease. Okay, would that work for this guy? You go and you take all this nerve down, he gonna get well? No, because he still has a string going through here. So this is not you wouldn't do that for this. So this is an operation you would use for somebody that maybe had peptic ulcer disease. You went back and you biopsied it, found out it wasn't cancer, treated him for H. pylori. 6 months later, you scope him, and he's still got some ulcer disease in there. And you might consider this. There's nothing really wrong with the stomach, but except for the ulcer disease. But you might consider doing this and getting acid secretion. Okay, so now here's another one. Vagotomy and pyloroplasty. Vagotomy and pyloroplasty. You go up around the trunk, you disrupt the vagus nerve. If you do that, is your stomach going to empty? No. So you're going to have to do, anytime you do a truncal vagotomy, you must do a drainage procedure to go with it. Something to help the stomach drain. So this is called Heineke Miculix, and basically you cut a longitudinal or horizontal, I guess. That's a vertical, I don't know. You cut across the pylorus in a line, and then you sew it back the other way. And I'm trying to think of any way I could demonstrate that with a piece of paper. Makes more sense. Okay. If that's your pylorus, you make the hole. If that's the stomach if the stomach is the blue side and the duodenum is the white side, you make the hole this way. Okay. Then when you sew that together, that'll widen it. It makes it wider. Okay. Maybe I'll bring something next week and explain it better. But anyway, so that's called Heineke Miculix. It widens the pylorus and stuff can drain through that. Could you do that for him? No, because you don't have a hole. That's the problem. There's no hole in there anymore. So it's not like this anymore. It's like that. So there's nowhere to make. It's going to be stiff, and you're not going to be able to make it go sideways. Okay. All right. So you're pretty much stuck with a vagotomy and a nephrectomy in that patient population. Yes, ma'am. Well, interestingly enough, usually not. I mean, most of the time, the reason you do the drainage procedure is to keep them from having to have motility agents. And if you look at, sometimes they do have small bowel complications where you may have to put some people on motility agents. But these operations have really unbelievable types of complications, and I'll get into that in just a minute. So but that's a good question, and mostly no, but some people may have to. So what you do here, you cut the stomach out. You actually remove this part of the stomach, the antrum and the pylorus, and then you sew it to a piece of small bowel. You close the duodenum side of it, so all of the bile acids and everything are going to pass through, will come on down here, and your stomach is sewn to your jejunum. All right, it's a weird situation, but if you're desperate, it works. Okay, we don't do very many of either one of these operations. I did these every night when I was in training because there was no such thing as Nexium. So once they developed H2 blockers, and then we very rarely did this almost exclusively now for gastric outlet obstruction. We almost never have to do it for anything but that, or gastric cancer. So those are the operations. That's kind of what you use it for. You can't use pyloroplasty for gastric outlet obstruction, but you could use it for recurrent ulcer disease, intractable pain, things like that. Or bleeding, if somebody has multiple episodes of bleeding and they're not obstructed, you could go in and do a pyloroplasty. A lot of people prefer this operation because you don't have to take the stomach out and there's not a bunch of suture lines you have to worry about breaking down. Okay, here we go. This patient is recovering now. You did a vagotomy and enterectomy. You were smart. You took out the stomach. You hooked it all up. He comes back 6 weeks later. He said every time he eats a big meal, 30 minutes later, he gets flushed, he starts getting dizzy, he feels bloated, he feels like he's tachycardic, then he's like he's going to faint. Okay, that's what he feels like. So the treatment for this patient would be, which one of these? Avoid high carbohydrates, drink plenty of fluids, lie down after he eats, octreotide, or revise his stomach surgery with a Roux and wine. Okay, accept. The answer is accept. Which one of these are you going to tell him you're not going to tell him to do? Don't drink plenty of fluids, okay? Because this is what's called dumping syndrome. Okay, so I'm just going to go over 2 of these complications. Fortunately, I don't think it's not in the book. It just says there's like 9 million complications there are. I'm only going to give you 2 of them that you see a lot. So this one, your stomach is now just hooked up to your small bowels, right? It's no longer, there's no pylorus. There's nothing so that you squirt a little bit of stomach contents into the small bowel anymore, so it just gets dumped in there all at one time, dumping syndrome. And what happens, all that time, you sequester fluid, so the patient gets a little bit volume low, because you're sequestering all your fluid into that area. You can get vasomotor symptoms, and you get a bunch of insulin released all at once too, so the patients tend to get a little bit hypoglycemic, so after they eat, they get all of these symptoms. And so what you have to tell them to do is eat small meals, small frequent meals. Don't eat a high carbohydrate meal. Do not drink a bunch of water with it because it's just going to make it worse. So small dry meals and lie down. And if the symptoms are really bad, you can give them octreotide. Most patients, this will resolve in a few months. They'll stop getting the symptoms. But for people that they just keep having it, it is a very big lifestyle alter. If you have vagotomy and enterectomy, you're going to have a lifestyle alteration, period. But this is really inconvenient for the patient. Sometimes they can't work, things like that. So for those patients, you may want to go back and revise that surgery. Okay, and then there's one other one that I'll go through quickly. There's another guy. He did his B2. 6 months later, he comes back and says he's having diarrhea all the time. He's lost 10 pounds, his stools are floating, you check his lab and his hemoglobin is 10, and he has megaloblastic anemia. This one is called blind loop syndrome, and it's where remember where we said here, you see this setup here where you've got this loop here, this blind loop here can fill with bacteria and have overgrowth and cause all of those symptoms to happen to the patient. So most of the time what you do for that, it also interferes with B12 absorption, okay? So the patients get a megaloblastic anemia. So for those people, you give them a course of antibiotics, give them B12, tell them not to drink lactose, and sometimes you have to do surgery. And all sorts of things can happen. I'll skip over this one. But all sorts of things can happen in these afferent loops, okay? They can obstruct, perforate, all the above. So after you do this surgery, you have to follow these patients for a long time before they feel well. All right, Zollinger Ellison, this is like the darling of all textbooks. It's probably something you won't see very much, but Zollinger Ellison is a gastrin secreting tumors, and they cause ulcer disease. due to excessive GI tract acid production. And this is not just somebody comes in with an ulcer, they come in with multiple ulcers, or you're treating them for months and they don't go away, or they have serious complications. So these, you treat these by resecting the tumor. And sometimes you can't resect the tumor, sometimes you can't find the tumor, and you may have to treat with just H2 receptor agonists or PPIs. So I'll tell you that the book had something in there that wasn't correct, but I don't think anybody knows what's correct, and I'll show you that in there. Okay, which of the following about Zollinger-Ellison is true? It usually presents with epigastric pain, heartburn, and diarrhea. CT scan is not useful in localizing tumors. Cure rates are high, and especially with MEN1. If a gastronoma cannot be localized, preoperative surgery cannot be recommended, and most gastrinomas are associated with MEN syndrome. Only one of those is true. Do you know which one it is? It's the first one. They usually present with epigastric pain, heartburn, and diarrhea. Okay, CT is very useful in finding them. Sometimes secretory, angiography, to look for secretin levels. And then if you cannot localize the gastronoma preoperatively, you can still recommend surgery to the patient, because a lot of times you can find it intraoperatively, either just by looking around or with ultrasound, because CTs can't really find things very well that unless they get to at least 7 or 8 millimeters, or about a centimeter. So sometimes they can't. Okay, and then where's the location? Your book said 80% duodenum, 20% pancreas, and I didn't think that sounded right, but when I looked it up, there's all kinds of papers. Most of them, let's just say, most of them are in the duodenum, okay? And then the pancreas is the next most likely, but they can be in other locations as well. So I just want you to be aware that it's not really 80-20, all right? Okay, all right, and then this is the workup. So you draw we won't go through the whole thing, but if you draw a gastrin level and it's greater than 1,000, the patient has Zollinger-Ellison. If it's less than 110, they don't have Zollinger-Ellison, and if it's in between, there's a much more detailed workup they have to undergo to figure out if they have Zollinger-Ellison or not. But mostly just remember that if they have a very high gastrin level, they have Zollinger-Ellison. And you would think about, when would you think about testing somebody for Zollinger-Ellison? I mean, not everybody comes with the ulcer and goes, you could have Zollinger-Ellison, right? So, what? Recurrent, when they are having recurrent disease, or they're having more ulcers after you give, they don't respond to medical therapy. All right, that's when you're going to think about it. All right, or if they have MEN, obviously. Okay, so morbid obesity surgery. This is not my specialty, so I wish I had somebody who knew more about it given this, but I know something about it. So 35% of the U.S. population is obese. Probably in Tennessee, it's higher. If you go to Colorado, 17%. Okay, so it really varies from state to state. But the southern states and Michigan, yes, thank you, Michigan. All of you Michiganders, y'all are saving us, because y'all are the fattest people in the country. Right, so that is, then the South, we are right on you, and we're going to take you over, I promise. So morbid obesity, the BMI is greater than 40. So what are the indications for morbid obesity surgery? BMI greater than 40. Okay, if the patient can tolerate it. All right, and then you can go down to a BMI of 35 if the patient's having a complication. What's the complication of morbid obesity? Yeah, the diabetes, hypertension, sometimes severe joint immobility issues could be considered. And then, or if they have a BMI greater than 35 and they fail to lose weight on a medically supervised weight loss program, that's also another indication. And they have to meet a lot of criteria to undergo morbid obesity surgery. And these people are going to be in the clinic for a while. So if you end up in one of those clinics, you're going to see this person multiple times. First of all, you're going to make sure that they were in a medically supervised program and couldn't lose weight. Okay, that's the first thing you're going to do. So they're going to be with you for several months just for that part of it, unless their BMI is 40. But I would say half of the operations are undergoing in people BMI of 35. Okay, and then they can't be abusing alcohol or any substance, and they can't have any medical contraindication of surgery. This gets a lot of people out that want morbid obesity surgery because they're too medically, have too many medical problems, and they're no longer a candidate for it, heart disease, things like that. But if they're still medically okay, and then they're gonna have to see a psychiatrist. So all of these folks get psychological counseling. You have to make sure they're willing to cooperate with you, because I'll show you these operations. Once you do this, you cannot go out and eat, a big meal for a very long time. And that's the whole point, is it restricts your volume that you can take in. But you can't be so crazy that when I tell you can eat one cup of food and that's it, that you'll go out and, go to McDonald's and get a number 6 or whatever it is that you like, supersize, because you're gonna kill yourself if you do. Okay, so they have to be cooperative. These are the two. There's a lot of different procedures. If you look through there are like 35 different procedures that have been invented for weight loss, but these are the two that you're gonna see now, okay? So one is the Roux-en-Y, and that's where you take a loop of small bowel, jejunum, and you actually cut you put a staple, you staple the stomach, and you just leave just a little bitty pouch of stomach that'll hold maybe about a cup of food in it, and that's about it. And you'll take this roux limb, that's called the roux limb of the small bowel, and you sew it to that so that it empties into that small bowel now. And then all of the place here you gotta sew this in somewhere because it's got, your gallbladder secretions and your pancreatic secretions. So you sew that into the side. So that's called both restrictive. Okay, so it restricts the size of your stomach, and absorptive. It bypasses some of your absorptive surface. So this is a restrictive and absorptive approach to obesity. Okay, the other one you'll see, and surgeon to surgeon, most of them like to do either one or the other, although they're all trained to do both. It's just called the gastric sleeve. And what you do there is you just go all the way down the side of the stomach and eliminate most of the stomach. And you just take it out. You make a little incision and pop that stomach out, and it's gone, okay? And this sleeve will do the same thing. It'll hold maybe a cup and a half of food, and that's all the patient can eat, all right? And a lot of people prefer this. There's advantages and disadvantages to both of these procedures. Is this an absorptive and restrictive, or both? It's mostly a restrictive, okay? There's a little bit of absorption of maybe sugar from your stomach. There's not much absorption that goes on in your stomach. So this just restricts your stomach size so that you're not, you shouldn't be able to eat. What happens with time is both of these can be stretched. So sometimes we see people that lost a lot of weight and they'll gain it back because they'll stretch it back out. But they try to psychologically counsel and eliminate people that will do that. Okay, so those are the operations that mostly are going to get done. There's like 3 or 4 other ones that were done in the past. You may run into people that have had those old ileal bypasses. I do sporadically have somebody come in. But people that had the original ileal bypass, most of those people are dead because they all got cirrhosis from it. So you hardly ever see that. But those other operations you may see sometimes. Okay, so now this is a lady, you've already done that. She came in, she's 36 years old, BMI is 42, and you gave her sleeve gastrectomy, and she's been in the hospital for a couple of days. She was looking great. And on post-op 3, she says, my stomach is starting to hurt, and I need more Dilaudid. You did not give me enough Dilaudid. And you look on there, and you see she's been taking the Dilaudid like every 4 hours, as often as she can get it. And when you do her belly exam, it's certainly, if you see, if you do a belly exam, she's definitely more tender than she was the day before. Maybe has some mild peritoneal findings. Her temperature's 102, her pulse is 120, heart, respiratory 35, and her blood pressure's 90 over 60. What do you think happened? Yeah, probably lead along the staple line, and it's not that uncommon. Okay, so either you go right to the operating room. I would say at least half the surgeons I know that if they had that symptom, they just go on to the operating room. They wouldn't mess with getting the test, but the other half would probably get a test. And here you see the contrast material leaking outside of the stomach. Okay, so that goes to the operating room. And you can either repair the leaks. Sometimes you can see them and repair them with stitches. Sometimes you can repair them with another staple line. And some people, if you can't get it to repair, then you have to convert them to a Roux-en-Y. Okay, the other type. Okay, so that's just an example. Okay, and this is the last topic I think of gastric cancer. So the good news is gastric cancer is declining in the U.S. We don't see it as much. We don't really know why. They think some of it's due to changes in diet. We don't eat as much, grilled meat and hot dogs and nitrites and things like that, but they're not really sure. And there's two types. There's intestinal type. That's usually found in the distal part of the stomach. In people that had atrophic gastritis, H. pylori, if they've had a stomach infection in the past, if they have polyps, they're at risk. Polyps greater, if you see a polyp in the stomach and it's greater than 2 centimeters, there's a 20% risk that's cancer. And other things that affect gastric cancer rates are smoking, Epstein-Barr virus, same thing that causes, mono, okay, and dietary risks. So people that eat a lot of grilled food or a lot of processed meats are more likely to have it. And then the diffuse type is often in the cardia, and there's no ulcer or mass, and I'll show you a picture of the difference between these. Because the diffuse type, neither one of them has a great prognosis, but I can tell you that the diffuse type has a particularly bad one. Okay, so so gastric cancer can present as a mass, as a polyp, as an ulcer, as superficial spreading type, and then this is linitis plastica, where all the layers of the stomach are involved. It just looks like plastic in there, it's just a white sheet of stuff. So that it can be any of those ways. Okay, which of these statements is false regarding gastric cancer? Many patients present with weight loss, anorexia, and epigastric pain. I think that's true. Yeah, they can present with not much, but typically they've lost weight and they don't feel like eating. Okay, frank anemia is common. That's true. Are the most patients anemic? No, they're not. Okay, so that was the false one. Okay. Okay. You're only going to see occult blood about 50. Most of these patients don't come in with bleeding. In other words, that's not their problem. And occult blood in the stool is only present about 50% of the cases. So trying to diagnose this can be tough. Most patients have metastatic disease when they present. So most of them are going to be advanced. They're not going to come in early, okay? And Virchow's node is something you probably should keep in mind because it's kind of the kind of question they sometimes ask on exams. Virchow's node in the left supraclavicular space, if you feel a node there, then they're likely to have some sort of cancer in the abdomen. So this is a common way, and it would indicate the patient is more than likely not going to have a tumor that you can cure. All right, some other ways gastric cancer can present. Anybody know what that is? I'll give you a hint. That's the uterus. Ovarian. So these are ovaries, okay? And this is called Kuchenberg tumor. This is another way gastric cancer can present with involvement in the ovaries. And then this is this is called Bloomer's shelf or Bloomer's pouch, but I call it Bloomer's shelf. And you do a rectal exam, and you can imagine what that feels like in there. It's almost like there's a little shelf or rim, and those are metastases that are going on. Peritoneal metastases are very common with gastric cancer too. Okay, so those are other presentations for gastric cancer. Well, how do you work them up? Well, obviously you're going to have to do an EKG on them. You're going to want to get a biopsy and see what kind of cancer is it, because I'm going to cover the non-adenocarcinomas here in a minute. Okay, you're going to get an esophageal you're going to get an ultrasound to stage it to see if you see metastatic disease in the surrounding lymph nodes. You're going to CT them. What are you looking for? You're looking to see if you see lymph nodes all over the place. You're looking to see if they have ascites. Sometimes you can see METs on CT scan, but if you have to take somebody to the operating room for gastric cancer and you didn't see any METs on it, you still have to warn the patient. Say, okay, we didn't see any METs, so we're hopeful we can resect this, but some people have METs we can't see on CT scan. Okay, so PET scan is now popular for this too, to try to find the metastatic disease. Then if patients have METs, their CEA level will usually be high. What do we usually think of CEA levels for? Colon cancer, but they're usually high in gastric if they have metastatic disease. Okay, what kind of resection you do depends on what part of the stomach it's on, but most of the time you're going to do what's called en-bloc resection. En-bloc resection means you take one big whole piece out. I mean, you wouldn't go, so you're going to take the omentum out, and you're going to take the stomach out. You don't go take the omentum out and then go take the stomach out. You take it all out in one big block. So if it's in the usual location, which is the distal stomach, you're going to resect most of the stomach, the omentum, the lymph nodes, the left gastric artery, and then you're going to do a Billroth too, anastomosis. And then if it's up in the top of the stomach where the esophagus is, you're probably going to have to take the whole stomach out. So that's It's a big thing, and nobody, and I hope nobody tries to test you on a lymph node dissection because it's highly controversial. What you should do about lymph node dissection, there's no agreement on it. But in the U.S., mostly we're going to do what we call a D2 resection. We're going to take the stomach, we're going to take that left gastric, and then they're going to try to get the lymph nodes in the hepatic lymph nodes, celiac, and splenic lymph nodes. So we're going to do an extended lymph node dissection. But there's no agreement about what should be done. Okay, and then when you're done, you're going to have multimodality therapy. So you combine chemotherapy, radiation, and sometimes they can put seeding intraperitoneal. They can put little radiation seeded devices in the belly as well, and those are under investigation. The one trial that I think they did mention in there is a trial of 5-fluorouracil, leucovorin, and external beam radiation. If you think you had a cure, in other words, you feel like you got all the cancer out, doing that afterward, the patients survive longer. Okay, and the 5-year survival for this disease is still abysmal, 25%. So 1, in 4 is going to survive this for 5 years. All right, here's a couple other tumors that you may see. Gastric lymphoma, that's the second most common. So the most common, adenocarcinoma. Second most common, stomach cancer, gastric lymphoma. And it can be associated with this disease. Did y'all learn about malt? When I was in school, we didn't even have malt. I mean, people had malt, but we didn't have malt. So, this is something, some mucosal associated lymphoid tissue. And then I had a patient recently that had it. So you really do see it occasionally. Or non-Hodgkin's lymphoma. Risk factors, if they had H. pylori, if they've been on immune suppression. So you'll see these in patients that are transplant patients sometimes. They'll get it because they've been immune suppressed. Or people that are taking IBS, that although you have them all on the TV now, like if your skin looks bad, take IB. They all end in IV, but those are immune suppressants, and they are a risk factor for lymphoma. Some people have developed cancer while taking IB. They always put that. That's what they're talking about. All right, you diagnose this by endoscopy, and then for lymphoma, you're going to want to do bone marrow biopsy as well. That's for staging purposes. You're going to do a CT, and very few gastric lymphomas are going to be managed operatively. They're almost all going to be chemo, radiation. All right, and then there's the GIST tumors or GIST. I had a friend that died of the GIST tumor and gastrointestinal stromal tumor, and he called it a GIST tumor. So I don't know if it's GIST or GIST, but since he had it, I'm going to say it's GIST, okay? And it arises from I've heard it called both, interstitial cells of Cajal. Those are the origin cells. You diagnose it by staining for tyrosine kinase. Some of them, they're diagnosed incidentally inside of another mass. So they got something else taken out, and then they saw these cells in there. And if they don't have any metastases, then you resect these for the patients, and then treat them postoperatively with Gleevec, which is a tyrosine kinase inhibitor. Okay, and you would do that if the tumor was more than 10 centimeters in size, and they tend to be bulky, or if they have more than 5 metastases for high power field. So they get a resection if they don't have metastases, and they get Gleevec if it's a large tumor or an aggressive tumor. And they tend to not. They didn't quote the survival rate on this, but they tend to be large when they're discovered. So a lot of patients aren't really candidate for resection. Okay, and then I didn't manage to put this one on here, but this one is carcinoid. So you don't see that very often in the stomach. The most common location for carcinoid, you're going to find out next week, I think. Appendix. So that's usually where you find it. And they're almost always found incidentally. What do you think? Do you remember what carcinoid secretes?
Serotonin.
Serotonin, yeah. Secrete serotonin. So these people get flushing and stuff like that. The same, you get the post-turkey days. Supposedly turkey probably secrete serotonin is big because of the tryptophan in it or something like that. But, they get flushing, sweating. And I've seen a couple of patients that had the symptoms, and they'll just all of a sudden, it's coming suddenly. But most of them are incidental, and they can be associated with high gastrin secretion as well. There's a type 1 where they have atrophic gastritis, and the type 2 goes along with solitary Ellison syndrome. And a lot of times you just take these out with an endoscope. You don't have to always do surgery. The larger, more aggressive types, you do surgical resection if there's no metastases. So for stomach, the thing to remember for stomach cancer, if we don't see metastases, we'll take your stomach out, okay? So just keep, if there's metastases, we probably wouldn't, with the exception of if somebody's bleeding profusely, and then we might take your stomach out even though we know you're not going to have long-term survival, so you don't bleed to death, try to buy you some time. Okay, and some of these are gonna debulk. In other words, you know that maybe you're not gonna get rid of it completely, but you may be able to debulk it. And you can give octreotide for the carcinoid symptoms, and it'll help with that. Okay, any questions about gastric, stomach surgery, what we do, how we do it? All right, y'all done good.